Hello, everyone. My name is Cho Yin Yong from Verto Health. And today I want to cover how Verto is leveraging healthcare virtualization to compile an international patient summary. So first of all, who I am. Again, Samantha, I think you've covered it very in depth already, but just to reiterate, I am an engineering manager at Verto Health and also a lecturer at U of T Computer Science. I have 7 years of experience leading large-scale clinical implementations projects, which usually integrates with a lot of legacy systems. Um, so why don't we get started right away to kind of the background and the problem of what I'm going to speak for today. So first of all, to those who are unfamiliar, what is exactly the International Patient Summary? So essentially, the International Patient Summary is a standard which basically contains a minimal and non-exhaustive set of basic clinical data of a patient. So, for example, their allergies, their medications, their problems, and also what procedures they have taken, immunizations that they have, lab results, et cetera, et cetera. But what it is meant to do is to be readily usable by all clinicians for unscheduled patient care. So the patient can bring the International Patient Summary to anywhere that they have previously not gotten care before. And the physicians there are able to immediately kind of understand the whole patient background so that proper care can be provisioned. So with that said, there are many benefits of the International Patient Summary, and I would like to summarize it to three different personas that will be benefited from the summary. First of all, as I've said, the patient. The patient now has control over their health record, and they're able to bring this anywhere they wish. And most importantly, they can provide it to physicians that does not have access um, to their existing records. Now, for providers, this is also very, very useful. First of all, the IPS contains a minimal and concise view of the patient record. They are now able to kind of triage the patient more in context to the patient's conditions. On top of that, we have realized that the IPS is very useful for more efficient referrals with specialists. The specialist is able to better understand the patient from that referral, where in the previous case, they were left to regather that information directly from the patient. For health systems and population health perspective, the IPS is also very, very important. First of all, the IPS allows health systems to discover missed billing opportunities, which I probably would want to cover at the end of this presentation. And also, it unlocks the opportunity for population health analysis as a tool. So now going into why, compiling an international patient summary, why that is challenging is because data in healthcare is often very, very disconnected from each other. And it requires, in the end users, which is the physicians, to review and piece the puzzles together. This is a typical setup on how patient data is separated across many EMRs. For example, acute EMRs often broadcast messages via ED discharge summaries. The community EMR, in primary care, mainly has patient information stored in free text notes rather than structured fields like acute EMR does. And finally, perhaps in the specialist EMR setting, that the EMR is more advanced and is able to we are able to obtain resources to it through individual FHIR resources, through the FHIR API. Problem two is that specifically in community EMRs, and this is very common practice, is that clinical notes from a medical legal perspective is where it contains the most amount of clinically relevant informations for patients. So for example, although something like diseases which are billable is usually structured in disease registry in this particular EMR, similarly for prescriptions, it will be the same thing. Clinical notes often contain everything else. And they're very, very relevant. For example, vaccinations, whether or not they've taken certain vaccinations such as Mpox vaccine, COVID vaccine, hepatitis B, et cetera, et cetera. Social history and social determinants of health is another thing that we often see in free text clinical notes. Smoking and smoking cessation being two of the most relevant factors for risk factors for various diseases such as COPD, and also relevant lab results. And if those lab results have been contributory to a potential diagnosis, is often always written in free text notes. So how do we approach this? We approach this at Verto with healthcare virtualization, which is currently a patent pending solution that we've submitted. What is data virtualization here? So what Verto does is we compile different data sources to the Verto platform, but we also separate the data source and consolidate the data when we need to. And there's two steps to this. First of all, we have to consolidate the patient. So patients existing in different sources will have to be consolidated. And the second part is to consolidate patient health records. So, for example, COPD is mentioned in all three EMRs, but in the international patient summary, we would only want to see one COPD diagnosis. That in turn will allow for the consolidated patient summary record to be consumed. So first I want to talk about patient consolidation. We make use of our own in-house EMPI, better known as the Enterprise Master Patient Index. And essentially what it does is based on the business rules, we first link the patient between data sources so that they appear to the end user as one patient. For example, we can have an EMPI that matches on the same first name, last name, sex, and health card. And if they are the same, we consider these patients to be the same. So for example, an example here is John Doe. Although they have different IDs to refer to them in various EMRs, they have the same first name, last name, sex, and PHN. On the other hand, Jane Doe is not matched because, as we can see here, they have different first name and last names. So this is part one. And so this is an example of how that would show in our UI. This patient over here, Dave DeBronkart, is present in two different sources. And because they have the same identifiers over here, they are consolidated based on matching identifiers. As you can see here, we first ingested in this first data source, which is a FHIR server. And this is the second data source, which comes from a raw data lake. And it is matched based on our identity matching algorithm. An immediate question that could come up with, why do we need this dashboard? Now, this is to support dynamic patient linking and unlinking from a manual perspective. So on top of being able to programmatically link patients, we're also able to manually link patients in this dashboard, as well as manually unlinking patients that may be incorrectly matched together. There's another problem when it comes to consolidating patient health records. And this is the initial problem I talked about, which is the duplication across data sources. All data sources, and from what we see, represent clinical data points very differently. And here we may be familiar with a popular coding system, ICD-10, which is a very common coding systems that EMRs use to code their diagnosis. But there are also other coding systems that exist out there, such as ICD-9, which is an older version. Some people also may be familiar with SNOMED CT codes. And when we talk about procedures, there's LOINC codes as well. It's also possible that EMRs store this information not with coding systems, but with mnemonics, along with free text explanations. So, for example, to represent hypertension as a clinical concept, in ICD-10, we will represent that as the code I10, whereas in ICD-9, it will be represented as 401.9, et cetera, et cetera. In the mnemonic sense, hypertension is just represented as HTN. So Our solution to consolidate across these various coding systems is the concept of semantic normalization using the UMLS metathesaurus. The UMS metathesaurus is very comprehensive and contains 185 ontologies in one queryable metathesaurus. What that means is, although ICD-10, ICD-9, and other coding systems may represent hypertensions in different codes, UMLS contains one code to represent hypertension. In this case, as you can see, C0020538 is a representation of essential primary hypertension. On top of that, we are also able to map custom coding systems, custom concepts to UMLS, such as mnemonics like HTN. We're able to link these custom concepts to UMLS to support the consolidation of these clinical concepts. So now that we've semantically normalized these concepts, now we want to actually perform deduplication. As I've said before, it is possible that in many EMRs that the same conditions or the same medications be logged. In the international patient summary, though, we do not want these duplications. We want to be reducing noise for physicians, reviewing and using the patient summary, and that is one of the top priority that Verto as a platform aims to do. Here are two examples how Verto performs the deduplication of clinical objects. First of all, we use the most specific condition in multiple data sources based on a knowledge graph that we create. For example, in one EMR, it could be logged that the patient has type 2 diabetes mellitus unspecified, which is an E11 code in the ICD-10 world. Whereas in another specialist EMR, it could be logged that the patient has type 2 diabetes mellitus with kidney complications, which is a more specific ICD-10 code, E112. In the Verto platform, if we're able to see these two conditions appear, we're able to deduplicate the less specific one, which is E11, and select type 2 diabetes mellitus with kidney complications as the concept to display in the international patient summary. This is the example where the data is actually exists in one model, but we also support deduplication across multiple models. So in here is an example of medications. There are two different types of medication that can be logged in a particular EMR. The first is a prescription, which is something that a physician will initiate in the EMR so that patients is able to obtain the prescription in pharmacies. In the second type is a patient statement, a patient medication statement. This means that the patient is telling the physician that I am taking insulin, I am taking this particular medication. And so when we consolidate data across multiple data sources, we will get both prescriptions and patient medication statements. In here, the Verto logic is to deduplicate based on the prescription being the source of truth and using patient statement as kind of a supporting measure. We will also disambiguate the brand name, such as Lantus, into the more generic drug name, such as insulin. So that's how we perform the deduplication of clinical objects. Now that leads to a consolidated patient summary based on information from various data sources. And so as you can see here is a test patient, which has the patient summary displayed, which contains a full list of their health concerns, the medications that they're taking, possible immunizations, allergies, and also relevant procedures that physicians are interested in. The other thing that I haven't talked about yet is the idea of unstructured patient notes. So what we're doing actually is turning both existing EMM data and putting into relevant IPS buckets and also performing NLP on unstructured patient notes in order to come up with the final digital twin concepts for the patient. So as you can see in this example, although the EMR data has some information about their immunizations, some immunizations is also missed. In here, although tetanus is an immunization that they have taken and logged in both EMR, COVID-19 vaccine boosters and also the various vaccines that they have taken for COVID-19 is not in the EMR. However, combining these two, we're able to get a fulsome immunizations list to support the international patient summary. Similarly, for health concerns, myocardial infarction, also known as heart attack, exists in the disease registry, but not the type 2 diabetes mellitus, which is present in the patient notes. Again, we're able to consolidate that. Family history is another interesting thing because a lot of NLP technologies will only do string matching. And in this case, the patient may be misclassified as having CAD, coronary artery disease. In here, it is very important to take into the context of this particular disease. And knowing that this is actually a family history, we do not put that as part of the health concerns of the patient. Finally, we have the allergy section, which we directly put in the allergy and intolerance section of the IPS. When it comes to extracting free text fields, we understand that clinicians always have a concern of what is the accuracy of the NLP algorithm? We're using AI, is it reliable? And that's why it is especially important in showing the data provenance of where that disease came from in terms of the clinical note. We have one record that exists in the EMR, but we've parsed out 6 different health concerns for the patient based on the clinical note. So over here, as you can see, once you click on this button, you're able to come to a data provenance tab where you're able to see exactly where this parsed concept exists in the clinical note, and that we've accepted this concept with high confidence. If the patient decides that, if the physician decides that this is not the correct concept, they can also provide feedback directly within the app to do online fine-tuning of the NLP algorithm to ensure that we don't incorrectly recognize this concept in the future. So now I've talked about kind of the whole process. What are the actual real-life use cases powered by the International Patient Summary? First of all, once we've compiled a true copy of the patient summary across the entire patient population, this will lead to more accurate patient cohorting. So for example, you're able to ask questions like how many patients need to take a flu shot booster, or which patients have not completed an SDBBI test. Now, after asking these questions, now we're able to have higher success rates on downstream orchestration tasks. One huge use case that we kind of do is actually scheduling appointments for patients automatically if they fulfill the criteria in the patient cohorting. This allows for unlocking efficiencies for the health system. Right now, they do it manually, as well as increased billing opportunities for patients. That's for health systems. The second really cool thing that the consolidated summaries provide is the use of unstructured and structured data to allow organizations to make more data-driven decisions based on population health. This is a very important population health use case. And for us, we really found that is powerful for health systems to be able to perform semantic search on their population. This is an example where we've added the ability to free text query, like a Google search, their own patient population, patients with diabetes that are over 50 and female, And we're able to immediately obtain useful metrics about the patient population, such as the length of stay, the average patient age, the ER admissions, and other metrics. Um, and they're able to obtain that cohort to do, for example, also downstream orchestration tasks.